Ari, I want to hear basically your algorithm for, approaching a fistula where you think there is an outflow lesion to address.
Sure enough, I think there's quite a bit of crossover between what Omar said and what we actually do. So first, our office setup is a little bit different. We're in an HOPD, but we have a short tunnel or runway between the office and the OR, so it allows a quick evaluation. So typically we have 2 nurse practitioners that are working in tandem with me in the OR, and when we get a complaint from a dialysis center or the patient, we'll typically come to the office for an evaluation so that we can appropriately triage, because despite our best efforts to have consistent information about what the patient's complaint is, occasionally there's a disconnect. And, we don't want to bring people with sort of the expectation that they're okay or not well, just based on the say-so of the dialysis center. So what we first like to do is get a look in the office setting, and just what Omar said is the clinical evaluation, the history of the complaint, how long is has the complaint been surfaced for them, et cetera, how well have they been dialyzing, medications, confounding features, et cetera. And mostly we also will do that same ultrasound. Now, what we've learned about ultrasound is that it's particularly helpful when we look at the phase of that ultrasound. So it's not that you just get an ultrasound, but is it monophasic, biphasic, or triphasic? And what we like to see is that diastolic peak, at least 40 to 60% of the systolic peak, where you have real good flow through your AV access. As that diastolic peak starts to touch baseline and it inflect negatively, you have increasing stenosis within your AV access circuit. And now oftentimes we like to use the brachial artery as the surrogate for flow through that fistula, because it gives us a good baseline for inflow, and it lets us understand what is actually happening with that AV access circuit, because you have a uniform tube essentially in which to look at. Whereas when you get into some of these fistula, particularly if they become tortuous, and where you are within the segment of that access from the anastomosis on out towards the outflow of that access, some of those readings can become a little bit challenging and less reliable. So I think a real good baseline ultrasound tells you, number one, do you have a stenosis within the AV access circuit? And that also gives us, as you said, Omar, good flow measurement that we can reflect back on if we have a previous history with that patient. Now, if the clinical exam, corroborates with ultrasound, and it's interesting that the things that we see with ultrasound sometimes don't necessarily translate with fluoro, and vice versa. Largely they do, but they're typically synergistic studies where we can kind of anticipate one thing but not see it quite as well with another eye. And a lot of that has to do with where the eye is on the camera, as you're saying, using triplanar view or circumferential views versus not having those in a biplanar view. So the next phase for us would be, if the patient in fact has a stenotic lesion, we would determine where is that stenosis, because it starts at the heart and ends at the heart. So you can have inflow problems, you can have outflow problems, and then you can have conduit problems. So largely these problems are conduit problems, and when you look at the full body of access, most of those conduit problems tend to be at the juxta-anastomotic region of the AV fistula, or in swing segments like the cephalic arch or turn downs and such like this at the wrist, if you're looking at the wrist, et cetera. And then, of course, you can also have, main channel or cannulation zone type issues. But if you're laying your odds in AV access, you can almost identify in a predictable response where you're going to be having trouble. Radiocephalic fistulas tend to have more challenges at the juxta region and that early swing, whereas your upper arm brachiocephalic fistulas, even proximal radial artery fistulas, tend to have difficulties in the cephalic arch. And that's just a product of flow dynamics, and there's a lot of science we can go into if you'd like to, or we can just, we won't belabor the point.
I trust you on this.
Right,
all right.
Right. But, in the instance of let's just assuming we have a stenosis in the access circuit, and it really doesn't matter where it is, I like to look at the maturity of that access to determine where I'm actually going to do cannulation. And I think this is really where percutaneous fistulas have really changed the way we approach our access because it's really broadened our approach to being able to treat patients in a minimally invasive way. For example, we may have a new fistula that is not maturing, and that the device footprint is such that if you cannulate the fistula itself, you would run risk of having a hematoma that would even shut down the access because the diameter of your sheath is such that it occupies so much luminal gain, and that the hematoma and even manual compression would be enough to offset for future development. Or you have radial artery access, where you know that the anastomosis is sometimes challenging, but in a traditional approach where we cannulate the fistula proper in a bidirectional way, inflow versus outflow, and we uncover occult lesions, etc., coming around a very acute angle can be somewhat challenging. So what we have found is that distal radial artery cannulation under ultrasound is quite useful. You can either access through the princeps polyps artery coming through into the radial artery proper, or from the very distal radial artery, and allowing us to shoot angiogram through the radial artery itself, slipping a wire up into the cephalic vein, or even an upper arm immature brachiocephalic or proximal radial artery cephalic fistula or basilic, whatever the case may be. And that allows us to get a wire in at a much lower risk to that AV access, at which time we can then determine what the appropriate therapy is. Recently, I would say that, and that kind of brings us a little bit, I think, to the meat and potatoes of why we're here today, is I've been really strongly positioning the Flex device, the vessel prep device by VentureMed, and it's a really a fabulous device. And what that device does is allows us to treat stenosis over guide wire prior to actually performing an angioplasty, which is, by all measure, the staple therapy for most AV access maintenance. But what I think is unique about that device and separates itself from other devices that are in the space is the ease of use, but the crossing profile and the continuous 1 atmosphere of pressure that this device has. So polymorphic lesions are easily treated. So I have a video of that device in use that I can show later, and some photos that we can show about what that device looks like. But essentially, if we look at the device in crosswise, it looks like a Mercedes, where it has 3 struts that have microblades along the trailing edge of that access device that penetrate 0.25 millimeter outward. And so when the device is deployed with a thumb toggle and trigger, the device will open up, but at 1 atmosphere of pressure. We are working over an 014 or an 018 guide wire. You can isolate the stenosis of interest and then retract the device across the stenosis, re-sleeve, turn 90 degrees, and do 4 sequential passes so that you get 12 slices through that stenotic lesion, which is usually neointimal hyperplasia. Sometimes we have some calcium in there, but largely it's neointimal hyperplasia.